Hello, everyone. My name is Emily Beydler. I'm here today with Amanda Koire, and we're really excited to talk to you all about breaking new ground neurosteroid innovations in postpartum depression treatment. I'm currently a second-year psychiatry resident at University of Pennsylvania, and Amanda is currently an attending physician and researcher at Brigham and Women's Mass General and Harvard Medical School. So we have no disclosures, and just wanted to acknowledge that we'll sometimes refer to women in female when discussing patient presentations and statistics, given that most research has been done on people identifying as women or female in pregnancy, but want to acknowledge that this isn't completely inclusive, and there's other individuals who, for whom these conditions apply as well. So the first thing we'll talk about is why we need novel rapid-acting treatments for postpartum depression. So around half the population identify as women, and 85% of women become pregnant, with over 20% experiencing a perinatal mental health condition, which makes a very large patient population. And over 75% of them will never receive treatment. Additionally, mental health conditions are the underlying cause of 23% of maternal deaths in the United States. Because of the prevalence of perinatal mood and anxiety disorders and the severity of postpartum depression, there is this need for rapid-acting treatments, as well as further research, as they can be potentially fatal. So around 50% of patients, furthermore, respond to first-line antidepressants like sertraline for postpartum depression. So this leaves a good number of patients who are actually non-responders to the first-line treatment. And not all patients wish to take medications long-term. This is especially a consideration in pregnancy and postpartum, despite relatively reassuring safety data. So having a shorter course of medication is something that's often preferable for patients to limit fetal exposure or infant exposure. Like all of us likely know, there's very serious consequences of untreated postpartum depression, both psychiatrically for the mother in terms of suicide risk, as well as actually obstetric complications, both in pregnancy, like preeclampsia, preterm delivery, and after birth, neurodevelopmental effects on the child and impaired bonding with the mother. So our goal with novel rapid-acting interventions is to achieve maternal euthymia earlier, so none of these things progress. So I just wanted to go into what I thought was really interesting history of postpartum depression. So before we get into talking about some of the exciting developments and treatments that we have, I want to highlight just the amount of time and centuries that it took to get to this point. And in order to really develop these treatments, we, as a medical profession, really had to define postpartum depression. So the first mention ever of postpartum depression was that we know of was around 460 BCE. Hippocrates mentioned it in writing and attributed symptoms to lochial discharge. And later, like going into the Middle Ages, there was some attribution to moisture. And unfortunately, in the Middle Ages is kind of when the attribution of women exhibiting postpartum depression to witchcraft was started. However, in the 1850s, Dr. Marseille, who you may have heard the name of, given there's like a conference every year called Marseille, he actually published the first paper entirely devoted to perinatal mental illness based on 310 cases that he observed. So this was really important in terms of categorizing postpartum depression and not limiting it to like witchcraft or incorrect medical assumptions. Later in the 1900s, there was actually two American psychiatrists who kind of made us take a step backwards in the wrong direction. they proposed that postpartum depression was indistinct from depression outside of the perinatal period and actually removed postpartum psychosis as well as other modifiers from other diagnostic manuals in psychiatry. In the era of psychoanalysis, a lot of this was also attributed to like personal deficits, like personalities. But then in the late 60s, there were some studies looking at patient cohorts in the community. And this was like the first time this was really studied systematically. In 1994, DSM incorporated postpartum onset as a modifier for psychiatric illnesses for the first time, which is relatively recently, 30 years ago. And the next year, SSRIs were deemed the first-line treatment despite pretty limited controlled studies at that point. As you can imagine, in the one-year timeframe, there wasn't much progress in terms of efficacy and safety data. And these things started to become legislated in terms of treatment and prevention starting in 2006, with the first law passed to screen for postpartum depression. In 2008, there was a really groundbreaking development that dovetails into what we're going to talk more about in this session. Dr. Jamie McGuire, who was at the time a postdoc at UCLA, published her first work, the first work showing the role of dysfunctional GABAergic signaling in postpartum depression. And this was pretty amazing and even more incredible that she was a postdoc. And only around 11 years later, FDA approved the first medication specifically for postpartum depression based on the mechanistic work that she had done. And in 2023, we had the approval of the first postpartum depression oral medication, zuranolone. Okay, so we're going to highlight how zuranolone works and what it does through a hypothetical case example. So Miss C is a 32-year-old female G1P1 at 2 weeks postpartum. She has new onset of moderate depression symptoms that began 6 weeks ago, meeting criterion for major depressive disorder. Symptoms have not been sufficiently responsive to sertraline, which she started 4 weeks ago. She has no prior psychiatric history. She was breastfeeding, but stopped after a few weeks. She and her partner inquire if she might be a candidate for the new postpartum depression medication, and if there are any other interventions that might ameliorate her symptoms quickly. Oops. So in terms of some questions that might come up in a patient session, one might be how zuranolone works, if the patient is a candidate for it, how likely they are to respond, how quickly will they feel better, and should they continue on a medication like sertraline if they're to start zuranolone. Another consideration would be if they would be able to continue breastfeeding on zuranolone, and if they have other comorbid psychiatric conditions, would it be efficacious for those, such as anxiety? So hopefully by the end of this, the answers to these become more clear to everyone. So we're going to talk about first how zuranolone works, both synaptically and at other areas in the neuron. So this is an image I kind of modified from stalls. So allopregnanolone is the active compound in zuranolone and Brexanolone, which was actually sundown this year. But allopregnanolone is a neuroactive metabolite of progesterone, as well as a GABA-A positive allosteric modulator. And what this means is it doesn't directly open the chloride channel like an agonist would, but it modulates this activity to make that happen more easily. So, like I said, increases the inhibitory effects of GABA. And so it actually binds to two sites, both the synaptic site, if you can see like the kind of blue presynaptic neuron I put in there, it binds at that site as well as extrasynaptic sites. So at the intrasynaptic sites, this increases phasic inhibition, intermittent firing, and then at the extrasynaptic site, this enhances tonic or baseline inhibition, so increases the inhibitory effect of GABA at all times. I also want to mention a distinction from another class of medications that bind to GABA, which is benzodiazepines. So they actually only bind to the intersynaptic receptors and increase phasic inhibition, uh, unlike neurosteroids, which bind both intersynaptically as well as extrasynaptically. So now that we've talked about how zuranolone works, we can talk a little bit more about who is eligible for it and who can take it. So zuranolone is FDA approved for moderate to severe postpartum depression. It was approved in 2023, like we mentioned. And this is a 14-day treatment course in which patients take 50 milligrams nightly. And patients who were originally included in the trials who are eligible are from the third trimester onset of depression until up to 4 weeks postpartum. Treatment can be delivered at any time in the first year postpartum, but notably, it can't be prescribed during pregnancy itself. Okay, so in terms of how well zuranolone works, you can see here from a chart taken from some of the original trials, both the response and remission rates are pretty durable at 45 days follow-up, 62% response rate, and 44% remission rate measured on the HAM-D. And I also want to mention, you can see that there's benefit even pretty early on, like day 3, but you can see that there's kind of a jump after day 3. So if patients don't initially respond, it's still worth continuing the medication since there's a good amount that respond after day 3. Another notable finding from the original trials was that when looking at subcomponents of different scoring, psychometric scoring that they did, there was actually a decrease in anxiety, which they measured using the HAM-A questionnaire. So if a patient has postpartum anxiety as well as depression, it looks like there's some evidence that zuranolone might be helpful to patients like this.
So one question that's often asked is whether patients should continue their SSRI antidepressant if they're already taking one, or alternatively, if they should start one at the same time as zuranolone and use zuranolone as a sort of bridge while waiting for the antidepressant to take effect. Importantly, zuranolone is approved for use as first-line treatment for postpartum depression, so it isn't limited to use as an adjunct. My recommendation would be to continue their pre-existing antidepressant regimen to prevent potential medication discontinuation symptoms being perceived as intolerable side effects of starting zuranolone. Also, a follow-up study to the original clinical trial suggested that compared to the SSRI alone, adding zuranolone can produce additional clinical benefit, so you shouldn't hold off. However, I wouldn't start an SSRI at the same time as zuranolone if they weren't already on one, due to potential side effects from the SSRI. Plus, the patient might respond to zuranolone monotherapy. Side effects that do most commonly occur with zuranolone are somnolence, dizziness, and sedation. Mostly these side effects were tolerable. Almost everyone who experienced them did stay in the study. One aspect of side effects that we don't know as much about is effects on newborns exposed through breast milk. Lactating women were excluded from the clinical trials. For that reason, the formal recommendation is to pause breastfeeding for the 2 weeks while taking the medication. Unpublished data from the original study authors suggested that zuranolone is transmitted at low levels, so these recommendations may change in the future. With regards to dosing, zuranolone is prescribed at a dose of 50 milligrams nightly for 2 weeks. There is no taper at the end of the 2 weeks, they just stop. Withdrawal effects don't seem to be a concern for this medication. It should be taken with a fatty snack for best absorption. Because sedation can be a side effect that slows people's reaction times, even when they feel subjectively back to their baseline, they should not drive for 12 hours after they take a dose. And if they accidentally miss a dose, they should just skip it rather than doubling up the next night or taking it in the morning. I try to limit side effects like somnolence and sedation by lowering the dose if they're taking other nervous system depressants, have hepatic or renal impairment, or are on other medications that can interact with your metabolic enzymes to increase the effective dose of the medication. If someone does take far too high a dose, there's no specific antidote, and they should be monitored closely. The most common question I get asked about zuranolone is very concretely, like literally, how do you do it? So I'll walk you through it as the interactive part, step by step, and you'll see just how easy it is. You're going to run a benefits investigation, identify their specialty pharmacy, send the prescription, and potentially have to do a prior authorization depending on their insurance. The medication gets sent directly to the patient, and there's a number to call for one-on-one support, both for you as the clinician and for the patient if there are any issues encountered along the way. So as I said that, you may have been like, yeah, but what's a benefits investigation? So that just means you're using your search engine of choice to search their insurance name and the phrase benefits investigation. In this case, I searched Blue Cross Blue Shield, Massachusetts, because I'm based in Massachusetts, benefits investigation. And it prompts me right away to this site to type in the medication I'm inquiring about. So here you can see I've started typing in zuranolone. It takes me to exactly what I'm looking for, the 25 milligram capsules times 2 for the 14 weeks, and says, aha, yes, this is going to require a specialty pharmacy, which I'd already tipped you off as typical here. So then you go to the specialty pharmacy information. It says there's 3 choices. Here I decide I'll use the first one I see, and I would, since my hospital system is on Epic, just prescribe it the way I would any other medication, sending it to that specialty pharmacy. And then they ship it directly to the patient.
Amazing. So zuranolone is the current treatment options available, but we're excited that there's actually several more in the pipeline currently in clinical trials in the United States. So the first one I'll talk about is called ganaxolone, which is actually already FDA approved for a seizure disorder. You can see the ad on their website. This is like a congenital seizure disorder, CDKL5 deficiency. And ganaxolone is also a positive allosteric modulator, both at synaptic and extrasynaptic GABA-A receptors. It's available in IV and oral formulations, and it's currently in phase 2 trials for postpartum depression. The second drug in clinical trials currently is one that just has an investigational name so far, Nora 520. This is an allopregnanolone prodrug with a similar mechanism like we've talked about, and is currently in phase 2 trials. The way it was biochemically designed was to improve bioavailability. And then the final drug that's currently in the pipeline is one called BR2-296. This is an allopregnanolone prodrug in long-acting injectable formulation that's given intramuscularly to patients, which allows for sustained plasma levels for 3 to 4 weeks. So it currently completed phase 1 data. It was safe and well tolerated with no major side effects, and completed phase 2 clinical trials as well, but results are pending in terms of public availability. This seems like a promising option potentially for patients with adherence issues to just get a shot once a month. So returning to the case, hopefully we can answer some questions that we posed earlier in the session. So if the patient asked, am I a candidate for zuranolone? Hopefully everyone could answer at this point, yes. And in terms of how it works, it's an oral synthetic allopregnanolone analog. Like we mentioned, it modulates GABA activity, increasing inhibitory effects. If a patient asks how likely they are to respond in this situation, you could share that basically over half of patients respond by the end of the trial of the drug, and just under half are still in remission from depression at 45 days. In terms of how quickly people feel better, many notice improvement within 3 to 8 days, but recommended completing 14-day course, even if the benefits not immediately noticed, since people can also respond later in the treatment course. In terms of continuing a sertraline prescription while initiating zuranolone, some data does show greater benefit to doing this, so we would recommend doing that. In fact, in terms of ability to breastfeed, officially the recommendation is no at this time. There's always an option for patients to pump and dump in order to preserve their supply. just because if patients stop lactating or stop pumping, it can be difficult to resume breastfeeding, and they can resume after the medication course is completed in 2 weeks. If patients have anxiety symptoms as well, there's some evidence that anxiety symptoms are improved on zuranolone. I just wanted to highlight this. While I was researching this talk, there was this post on Reddit that I came across actually with a patient who was describing her experience with zuranolone, and she described in depth going through the steps that Amanda highlighted and how easy it was to work with the specialty pharmacy. But I thought that her narrative description was really poignant. She said it saved her. She felt like she wished she had started the medication sooner, since it seems like she started the medication several months after the depression developed, and felt like night and day after completing the treatment course, and left this really hopeful and reassuring sentiment to other patients that they're not alone, and that they're great mothers. So I think that there's a takeaway that, we should be prescribing early and often for patients, and not delaying treatment, because it can really affect their quality of life and experience as a new mother. So in summary, neurosteroids represent a paradigm shift in the treatment of postpartum depression in terms of their rapid onset. We talked about nuances in terms of patient selection for zuranolone currently, and there's a number of future treatments that are really promising but are still in clinical trials. If anyone has any questions, also feel free to contact Amanda and me. And here's our references.